Hello and welcome everyone to this digital discussion on how data can be used to support women's mental health during COVID-19. I'm Emma Smith, a reporter with DevEx and currently based in Scotland. Thank you to everyone for joining us today from so many different parts of the world. Today's conversation is part of a series of events hosted by DevEx in partnership with Facebook. So over the course of 10 weeks, we're going to be digging into how data can be used to mitigate the impact of COVID-19 on women and girls. Already, we have been looking into how unconventional data can inform the response to gender-based violence and how data can be used to increase access to care for women and girls. We have several more great events lined up in the coming weeks, so do keep an eye out for those, and you can join the conversation online using the hashtags #GenderData and DevExEvent. So the focus of today's event is mental health, specifically how women's mental health can be better supported during this crisis. So even pre-COVID, certain mental health problems such as depression were already more likely to affect women than men. Figures published by the World Health Organization suggest that women are twice as likely as men to suffer from unipolar depression. This is predicted to be the second leading cause of global disability burden by 2020. And gender is critical in determining mental health. For example, gender impacts a woman's socioeconomic control over her own mental health and life, as well as her status and treatment in a society, and her susceptibility and exposure to certain mental health risks. Different factors and events can also contribute to the risk of mental health. So early adverse life experiences, such as trauma or abuse, or experiences related to ongoing medical conditions or feelings of loneliness and isolation. These are just some of the factors that contribute to mental health. And of course, these are not exclusive to women, but certainly do affect women and disproportionately so in certain contexts. So why is addressing women's mental health so critical? Well, mental health is really closely related to physical health, and prolonged mental health issues can increase the risk of many types of chronic health problems. Poor mental health also impacts a woman's livelihood and productivity. And where women are mothers and caregivers, mental health issues can also have a huge negative impact for the entire family around things like child nutrition, participation in health initiatives, and whether or not a child attends and succeeds in school. As we've probably read or heard in the last weeks, there are a lot of ways in which women are being disproportionately impacted by this pandemic, and this is putting a greater strain on their mental health. Around the world, women tend to hold the most precarious jobs, and so many have already lost out on their livelihoods and their financial independence. Women also tend to be the primary caregivers in many households, and during this pandemic, they have been further burdened with the roles of homeschooling children, as well as caring for sick family members. As we heard in last week's event, women make up around 70% of the global health force, so right now, many of them are involved in those really challenging frontline jobs. There's also been a huge rise in domestic violence globally as a result of the lockdowns, and many women at the moment are isolated from family and friends, yet stuck with their abuser. These are just some of the knock-on effects of the pandemic, which are impacting women's mental health, and we're going to dig into these a little more in today's conversation. We're also going to find out how organisations are adapting their mental health interventions during this pandemic, and explore how data is being used or could be used to inform mental health services for women. We're going to hear from three panelists who work on mental health issues and have experience leading women-focused interventions. Before I introduce them though, just a few quick notes on today's event. The event will last about an hour and include a moderated discussion followed by a short presentation where each panelist will share with us their calls to action around improving women's mental health services. There will also be time set aside for some Q&A at the end, so do stick around for that. And if you have any questions for our panelists, then make sure to submit them via the Q&A box at the bottom of your screen. If you have any technical issues during today's event, you can use that same chat box to let a member of our team know and they will assist you. Finally, today's event is being recorded and we will send you the recording and a copy of the slides afterwards, so not to worry if you miss anything. So our panel today is made up of three experts in mental health and women's focused interventions, and hopefully we're going to have everyone join us on the screen now. First, we have Mwende Mwenda, who is a mental and emotional wellness practitioner in Kenya. We're also joined by Sarah Mosley, who is the Senior Technical Advisor for Women's Protection and Empowerment Programming with the International Rescue Committee. And finally, Sean Maybury, who is the founder and executive director of Strong Minds, which is a social enterprise focused on providing mental health services to women in Africa. A huge thank you to all of our panelists for joining us today. Really great to have you all with us. So Mwende, if I could kick things off with you and ask you to tell us a little bit more about the specific needs and vulnerabilities of women at this time with regards to their mental health. Sorry, Mwende, I think you might be on mute, just to, there we go.
Sorry about that. So thank you so much, Emma. Thanks for the introduction, and thanks to everybody who's currently in the meeting. Yeah, to answer your question, I think some of the challenges you have, of course, already mentioned. I will kind of bring it up very specifically to what I know is happening in developing countries such as Kenya and maybe other African countries, where we're seeing that, as you said, women are already making up a huge percentage of the workforce all over the world. More so in developing countries like Kenya, where we have women are truly the primary caregivers. As you said, now we have children who are primarily at home. And there's also a lot of subsistence income at a home level through, in rural areas, the farming work that is being done by women. And again, caring for very young children, caring for elderly parents. And what we see also happening in the urban areas is over and above the middle and upper level professionals who are women. We then have at the lower levels of income living in kind of some of our urban dwellings. Women are the ones who are primarily going out and earning incomes through very menial jobs, either through cleaning and trading at a very street level. And there is that pressure that they're experiencing from shrinking incomes, I think, all over the country, as it affects them in terms of what their own earning capacity is. So keeping in mind that there is that income disparity that already exists, and that's getting worse, and their primary roles as caregivers is not changing, there is a lot of pressure that women are experiencing at this time.
Great, thank you, Mwende. I think kind of giving us an overview of some of the challenges we're going to be talking about today. Sean, if I can jump to you next. I know that Strong Minds has primarily focused on supporting women with depression, but I understand that in recent weeks, the organization has scaled up its services. Could you tell us how you went about kind of scaling up the services to meet the growing needs that you're seeing, and what role did data play in helping you do that? Sorry, Sean, I think you're also on mute. There we go.
There we go. Traditionally, for Strong Minds, we conduct face-to-face therapy groups, so person-to-person to treat depression. We've treated over 70,000 women, but obviously with the pandemic, we're not able to do that. But we're responding to the challenge. What we've done in the last about 4 weeks is we've actually reached out to over 11,000 of our former patients on the phone and conducted 30-minute screenings with them to really understand how are they faring in terms of depression, stress, and anxiety, and conducted a number of diagnostic screenings with these 11,000 women. We really learned that some of them are staying strong thanks to the lessons and skills that they've developed through our intervention, but about a third of them are struggling with increased levels of depression. They have heightened levels of stress and anxiety. So we're really using that data to inform our next steps, which is, because we can't go out into their communities and conduct face-to-face groups, it's really about coming up with a simple telephone-based therapy, teletherapy. So it's really using the data that we collected to really inform us. And the big learning there is we really have to address stress and anxiety, which is not something traditionally that Strong Minds have done. So using that data to inform us, we're reaching out to experts, modifying our psychotherapy approach that we can address not just depression, but stress and anxiety, and really begin to deliver these critical mental health services to the thousands of people in Uganda and Zambia where we operate, just to help them.
And so while I've got you there, Sean, could you give us an idea of what kind of data is available in Uganda and Zambia in general on kind of mental health and women's mental health problems?
There's not a lot of data. We've been in Uganda for 7 years, Zambia for 2 years. In Uganda, there's just a little bit of data that can really inform you a little bit about rates of depression in some areas of some districts. In Zambia, where we entered in 2019, there is literally no information on depression in the country. We're the ones who are really kind of providing and creating and finding that data now. it's really that lack of data that I think we'll get to later in today's discussion that just leads to mental illness so often being last on the list of interventions, because the health agencies and many NGOs and other partners aren't really collecting this data. The problem goes unseen and unappreciated.
Great, thank you, Sean. And yes, certainly something that we'll dig into a little bit later in the conversation. Sarah, I know that IRC has worked pre-COVID as well in kind of providing mental health support to vulnerable populations. Could you tell us what kind of, what do you already know about those populations or the women within those populations with regards to their mental health? And what kind of additional data are you getting during this pandemic, which is helping our kind of understanding of their needs right now? Sorry, Sarah, can you also unmute? I think we'll all get the swing of it. There we go.
Hey, thanks. Yeah, I mean, we work in 32 countries with women's protection and empowerment work, which is what we call our gender-based violence work. So in addition to mental health services through our primary healthcare work. So we see a lot of women and girls. And, you know, similar to what my colleagues already alluded to, you know, we're seeing a lot of additional stressors, exacerbated gender inequality, as well as exacerbated disparities, particularly related to gender. And I think, you know, what I would say is, you know, losing your job, having additional household responsibilities, having your kids at home, like on their own are enough to create a lot of anxiety and stress. But what we're seeing is that these are also driving or compounding intimate partner violence. So we're seeing a lot of increases. We're seeing actually two things in terms of our data. We're seeing either a lot of increases in reporting and requests for assistance, but we're also seeing in a lot of contexts we work which are rural, connectivity is low, women and girls don't have a lot of access or control to technology. Where static services have had to close down, we're also seeing very dramatic drop-offs in reporting, which is really concerning to us because we do know, like we've continued to conduct remote safety audits. So it's a system where we have a community focal point and we're checking in weekly or bi-weekly to go through a list of risk factors for women and girls in the community, including risk factors for intimate partner violence and sexual violence. And those are remaining constant, if not increasing, and yet we know that they can't get to static services that have closed. So we're seeing kind of two trends in terms of the data, so to speak, where it just increases, but then also decreases, dramatic decreases that we've quite frankly never seen before, and it's alarming. And to be frank, I forgot the second part of your question. I think you're on mute now, Emma.
We've all done it once, that's it out the way. What kind of additional data are you getting now during the pandemic that's actually helping your understanding of their needs?
Yeah. So for example, one has been these remote safety audits. So we track kind of a combination of risk factors within the community in terms of access to different types of basic needs, increases in social unrest or increases in military presence, again, barriers to critical water points. So we're tracking a whole series of what we would call, determinants or risk factors, which, give us a bit of a picture in terms of what's happening for women and girls, as well as other members in the community. I think that's been pretty critical. I know in past conversations that we've had, we're also really looking at our service utilization numbers. And so we're looking at who is able to actually access support. There's been a huge push, right, to switch mental health as well as a broad range of social services to remote and online platforms. And while that's fantastic and needed, when you start to look at the numbers as to who is actually able to access that type of support and that type of remote-based service delivery, you do start to, at least for us, like what we've started to see is that it really corresponds with a certain segment of the population. Adolescent girls have a much harder time accessing, even though they might be more tech savvy. In some contexts, they're a lot less likely to be able to control or access the phone. So we're just seeing a lot of disparities in who has access to technology, even within, women as a demographic.
Great, thank you, Sarah. So from conversations I've had since the start of COVID, there's been a lot of different organizations have told me they're concerned because mental health is one of the first areas to see funding cuts, and it's already pretty hugely underfunded. So some figures published recently by an advocacy campaign called Speak Your Mind tell us that on average, countries continue to spend less than 2% of their health budgets on mental health, and donor financing of global health aid, such as 1% directed towards mental health between 1955 and 2015. So already pretty hugely underfunded. Sean, maybe you can jump in. Why do you think that it's one of the first areas to see cuts, or why is it so underfunded in the first place? And how would data maybe help us there?
That's the biggest problem we have. We always say at Strong Minds, conducting our mental health in Africa is the easy part. The hard part is finding the funding. I think there's a lot of funders out there, be it institutional or individual, whatever they may be. They really just don't appreciate why mental health matters. And I think those that even think about it wrongly assume that mental health interventions will be very time consuming and will be very expensive. And there's also an issue with individual and institutional donors. There's still a lot of stigma around mental health. They choose to focus on easier things, however easy may be for that individual or organization. But ultimately, I think the biggest problem is those who even want to think about intervening in mental health, funding it, supporting it, just don't see it as an easy intervention to understand. So many donors are looking for the quick return on investment. They're looking for number of nets distributed, number of condoms distributed. And for mental health, a lot of people out there, funders, just don't understand and think it's going to take a very long time and they're not going to see a clear return on investment, which I think is so important. Why implementers doing mental health need to be able to quantify better and use data in terms of establishing baselines, midlines, endlines. How many patients have they treated, so that the donors out there can really see that it is a great return on investment. Those would be my points.
Wendy, I can see that you're nodding along there. I wondered if you have something to add from your point of view in Kenya.
Yeah, certainly. I think there's some things that Sean has said, especially in regards to why mental health is so underfunded. Even the work that I've been doing, especially this year, and targeting really institutions and speaking to the staff within institutions. One of the more interesting things that I've found some of the larger organizations, as Sean has mentioned, which would benefit from having conversation about mental health, like insurers, are finally coming on board with mental health practitioners to then find how do we, because they're not, as Sean has given a very good example, what is the return on maybe distribution of nets, for malaria or something like that, especially in developing countries, sorry. And now we're kind of looking at it, how can we reduce the cost of day-to-day healthcare interventions that are probably caused by mental health challenges? One of the more common ones that we see, I can say certainly in Kenya, is like we have huge numbers of cases of people who are suffering from hypertension or high blood pressure, a lot of which is just related to the mental stresses that everybody's enduring. Same thing with things like diabetes. And now we have people actually coming in and saying, look, how can we work with people's mental health to kind of give this holistic and whole aspect of them managing their lives to kind of reduce these incidences, which in the end do work out better at a monetary level, maybe for employers. And certainly would be good to see if we can have a conversation like that with the national health insurer, because then that would also see, they'd be able to then see it in terms of a reduction in claims, which then, gives that monetary value, which everybody kind of has to look at the end line. You're on mute, Emma.
Sorry, while I have you, Wendy, could you maybe briefly outline some of the practical and ethical challenges in collecting this type of data?
So yeah, that's a very good question. I think in partnership, maybe I find the ethical challenges maybe will be a bit more than the practical ones. I think practically, once you have probably our healthcare facilities at the lower levels. And really, I'm talking about those that are catering to middle to lower income communities in our country, because that is really the vast majority of the numbers that we have in a country like Kenya, would then be less so, because you then gone into your kind of health facility at either a level 1 or a level 2. We also really do rely a lot on, kind of walk-in clinics, so to speak, and kind of getting people to then share some very basic information like, look, I've been having this, constant headache for the last 4 weeks, 8 weeks, whether you're not able to really link it directly to some mental health challenge, but then have your practitioner or clinician there who can then do a bit more deep diving. And yes, it might be a bit time consuming at a very, therapeutic level at that starting point. But I think practically, I think it is something that can be done. Once you find organizations that are willing to fund and partner with these institutions that are working very much at the ground level. Ethically, yes, that is a good question, because you do kind of need everybody to sign off on what it is that you're collecting. And if you're dealing with somebody who really doesn't understand, I think at some of our levels, mental health is still considered an institutional issue, and we don't understand, as Sean has said, there's no data about stress, anxiety, depression, kind of language that is more available to maybe people who are operating in a middle to an upper level of income in these countries. So yes, ethically, there would have to be some thought that goes into explaining to the people who are coming into your institutions for first level of care what it is that you're trying to do.
Thank you, that's great. Sarah, can I ask you to maybe tell us a little bit about some of the factors that are adding to the difficulties in collecting data, especially sensitive data for women at this time, in the current situation?
Yeah, definitely. There's a lot of risk factors that come with, and safety factors that can come with trying to collect, particularly data that's related to experiences, personal experiences of violence. It's also, I think, like some of the push to use remote modalities for service delivery, or even, for data collection, don't always take into account the reality that a lot of women and girls are living with their abusers. So actually being able to respond to phone surveys or inquiry, like remote-based inquiries in a way that's safe. Because a lot of households don't have more than one phone. There are, lack of privacy issues, and all of that contributes again to getting data in a way that's safe and ethical for a lot of women and girls, particularly as it relates to experiences of violence. I think that the other challenge as well has been just to be, at least from our experience, we do GBV screening at our health, not everywhere, but we have a GBV screening within health facilities. So, theoretically, women and girls can get screened for whether or not they have experienced gender-based violence. But there is also just the reality of power dynamics, right, between health providers and patients, particularly in lower resource contexts where, consent is not necessarily perceived by the user, by the patient, as optional. So and it's also time consuming, right? It is also time consuming, which is another concern. And particularly in the COVID-19 context, we found as an organization, just from our Ebola response, that trying to transfer or trying to task shift some of this to healthcare workers just really doesn't work during large outbreaks, because they're already so overstretched, but also because health facilities themselves become stigmatized during outbreaks. People do not want to be seen as at the health clinic because of what the community can perceive. So those are some of the other challenges that as well as some solutions that we've been working with.
Great, thank you, Sarah. Sean, I wondered if we could reflect a little bit on the kind of work that Strong Minds has been doing in the last weeks and months and scaling up and using data to help you in that scale up. What would be some of the lessons that you might be able to share with other organizations in how they can use data around mental health at this time?
Sure. Yeah, there's a lot of reflections over the last few weeks as we've gone out. As we went out and spoke to about the 11,000 women, it was just an onslaught of data. It was like taking a drink from a fire hydrant. Just collecting all of that data quickly in our tablets and our phones, of course, caused our data app to just completely collapse on us, and we had to kind of figure it out. So in that sense, we just weren't ready to really spike up so much data from so many data points in such a short period. So for us, that was a learning. And for us too, I mean, our whole approach is just to move as quickly as we can to get out there. We could have spent a lot of time deciding what are the new diagnostic tools to collect the data. But for us, it was kind of just take the approach of let's do a 1.0 version next, and then a 2.0 version after that. And just to jump out there because we knew people are suffering right now with the pandemic, with the lockdown, and we wanted to be able to get that data as quickly as possible. So for us, it was about moving fast, get the data, and let the data then inform you, and then maybe change the diagnostic tool. Or are we seeing a spike in one area of mental illness, so we should dig deeper into that? So for us, I think that the real learning is just move as quickly as one can, collect the data, and then let that data lead you to the next steps. But then at the same time, with that data, we had a whole separate team that just started as soon as we saw the stress and anxiety rising. It was about, okay, let's innovate the program and to figure out using that data, how we can respond to it, if that's helpful.
And Sean, where do you see opportunities for other actors or maybe other sectors to play a greater role in helping us collect and kind of use this data?
Oh, there's so many opportunities. Certainly at the government level, when ministries are out there and district health surveys, really putting in a lot more information there to collect these baselines. Again, reflecting back on Zambia, when we started working and partnering with the Ministry of Health in early 2019, they just had no idea what the prevalence or incidence rates of depression were in their country. So certainly those are the big players, on the government side. But NGOs of all size, the more information that they can collect can help us all to really understand the magnitude of the issue. Right now, so many of us just look at the tip of the iceberg, but down below, under the water level, there is so much mental illness, and just one organization can't do it. So once we collect all that data, it's really starting to shine light on the issues, and then we can begin to move mental health up the list from the last position it's occupying right now, regrettably.
Wendy, do you have anything you want to add around the different organizations or actors that you think could play a stronger role here?
Thanks, Emma. Yeah, I think right now, yes, I think we still remain very challenged as a developing country in terms of what our government's understanding of mental health holistically is. As I said, traditionally, and even with the stigma, as I talk to people in Kenya, people still understand mental health to be some of the more extreme expressions that we see, and not sort of, the things like stress and anxiety, as Sean has kind of mentioned, the data he's been collecting. I know, for example, in Kenya, actually just towards the end of last year, we had, and before COVID, we had a mental health task force that had just been created under the Ministry of Health, really because globally there has been a conversation about mental health. So something had already started at that level. And there had been a commitment by the Ministry of Health to kind of start, rethinking how it is that we are dealing with mental health. We also have a law that's in place that is awaiting ascension, again, regarding mental health, and still really doesn't get into the softer ways of dealing with mental health issues. I certainly agree. I think right now, at a very basic level, your best chances for collecting data where mental health is concerned for middle to lower income communities in developing countries such as Kenya and maybe in East Africa would certainly be the level 1 and level 2 hospitals, which kind of operate and which are government-led institutions. If you're in densely populated urban areas, then you'll probably see clinics, private clinics operating a bit more. But one of the biggest outreach systems we have, of course, over and above the NGO system, and some like IRC, where Sarah works, is of course the churches. We've seen a huge outpouring of church. Of course, it's a developing country. The churches are still operating very widely. They are providing a lot of our mental health interventions at a ground level, both in rural and urban settings. So that would be also a good place and a good partner to have to kind of understand what are the needs of the community. And the church is always very plugged in on what's happening in the community. So I think those would be good partners as well.
Great, thank you. So I'm conscious of time and we do want to move soon to the kind of calls to action, but I wanted to ask you each very briefly, how do you hope that this crisis and the focus that it's kind of brought to mental health might not only change awareness, but approaches around these issues? Sarah, if we can start with you, and then if we can move on to Wendy and Sean, thank you.
How long do I have? No, I'm kidding. So I'm really encouraged and by the recognition. I mean, I worked almost 18 years now in humanitarian work, and this is probably one of the first ones where we just saw widespread recognition from, the UN Secretary General, the head of WHO, and others around the very real realities of violence against women and girls as it relates to this particular crisis. And so I'm really hopeful that the link between women's mental health and well-being and their experiences of violence is really strengthened and better just understood by the community and practitioners as a whole.
Wendy, if we can move straight on to you, thanks.
Yeah, thanks for that. I'll also keep it pretty brief. And I think I agree very much with Sarah. I think what I feel I'm seeing is that there's certain acknowledgement and change in the conversation regarding mental health. I think the words stress, worry, anxiety, depression are much more commonplace now at all levels. Maybe still not so much more, as I said, as I have conversations with individuals, both male and female, but more women at lower income levels. There's still that very basic survival need that's caused by their economic situation that they can't plug into the fact that, oh, I'm stressed or, I'm anxious, and that language kind of just doesn't exist. I've had quips previously, people saying, there's no word for depression in Kiswahili, which is the Kenyan language. It's no longer true. I think everybody's kind of acknowledging now there is something. So even though the word stress or anxiety is not traditionally there in our language, you're able to see somebody expressing that either I'm really tired, I'm not able to get out of bed. And it's just for us as practitioners to then be able to kind of have the conversation with them around what's going on. But now it's really brought it all to the surface. And I'm also really hopeful that we'll take this as an opportunity, as Sarah has said, to just reach out, to bring down the stigma walls. I think everybody's kind of going through it right now, and this will be a good time for us to just bring mental health to the forefront.
And Sean?
No, I agree with the other speakers very much. While of course the pandemic is so tragic for the planet, there's a huge opportunity here on mental health about really increasing the level of awareness. We're seeing this in Uganda, where the Ministry of Health is working together with us now for the first time in 7 years to deliver mental health messaging in radio and TV and on social media. They're really understanding how important this is. I think it's also an opportunity to really just force even increased innovation for implementers on their mental health models. For Strong Minds, we've been conducting groups for 10, 12-week periods, and we're stepping back and going to the drawing board now and saying, how can we cut this down to 3 and 4 weeks? Just because we know the increase in depression is something we have to respond to. So even forcing more innovation. And it really is a chance for implementers to show the world that you can address mental health in simple ways using task shifting at really low costs. So creating that visibility. And it's really, at the end of the day, it's really just getting mental health into the global health lexicon, right? Just so that we can talk about it. Even now today, I'll go to conferences and there'll be all these breakout sessions on malaria and HIV, and then they'll lump everything together in mental health in this one giant category. So this is an opportunity for the world to really understand the complexities of mental health and the necessities for it to be addressed.
Great, thank you. And I am conscious of time, and I see we already have questions coming in from the audience. But before we get to the Q&A, we're just going to have a very brief presentation here. And if I could ask each of the panelists to take just a couple of minutes to tell us more about their calls to action, which we should also be getting up on the screen now. Wendy, if you could start, and then we'll go straight to Sarah for your call to action, and then finish up with Sean. Thanks.
Hi, Emma. Thanks for that. I'll keep it pretty brief. For me, the calls for action that I had specifically thought about in regards to this talk is, again, just an increase of awareness of some of the mental health challenges that are being faced by women and girls, especially in the middle to lower income communities of developing countries, both rural and urban. So what is, mental health? As I said, those words still have very huge weight on people. There's still a lot of stigma, so kind of breaking it down into very easy language, like stress, anxiety, what that looks like, what that feels like, and, kind of some of the outreach that's available. In terms of data, because we really talked about how to collect data, and I mean, we've gotten some really great examples from some of the other panelists of where they've gotten their data from, is partnering again with some of the church-based organizations, looking at some of the health facilities that are already working in the communities, in lower income communities. These would be good places to partner if your organization isn't able to kind of work in the space. As you said, there's still a bit of lockdown, curfews as we have in here in Kenya, and we may not be able to reach everybody who needs to be reached, but there are organizations that are already working in those spaces, and they would be good, first point of contacts, as well as some of the national organizations like the Health Insurance Fund. And to continue increasing the awareness on the escalating psychological pressure that women are experiencing at this point. They're primary caregivers, they are continuing to be the main subsistent income earners. And yes, it's a lot of pressure and just not understanding. You hear a lot when you ask somebody, are you stressed, are you tired? It's like, but it's just a normal kind of stress. It's the stress of being a woman. It's the normalization of, yes, this is what is expected of us as women and as girls, and in rural areas, you see them really undertaking a lot of very manual labor, fetching water, doing that kind of work. So it's just for me mostly about increased awareness and working with organizations that are already on the ground to kind of collect data that's there. Thank you.
Great, thank you. And if we can jump straight to Sarah, and if I can ask you, Sarah, to keep it as brief as you can. Thank you.
Definitely. So, I mean, my first call to action is that we continue to recognize and advocate that mental health services, as well as protection or social services, particularly services that work on the issue of violence against women and girls, remain essential. And I think a little bit linked to what Sean was saying earlier in terms of the lack of recognition, or why it's such a hard sell, that they're not just essential, but they're recognized as life-saving, and that we can't ignore the link between women's experiences of violence and their well-being, and that these mental health services and these protection services are indeed life-saving and critical at this particular point in time, and need to stay open and continue to operate. The other one that I would really encourage us is to really use feminist frameworks and women's empowerment approaches in our mental health work. We create a lot of cognitive dissonance for our clients, for our patients, when we're trying to work on women's mental health and well-being, but we're not acknowledging or giving them language and frameworks for the structural and systemic discrimination and inequality and oppression that they face. And particularly with COVID-19, and again, the heightened gender inequality right now, that's really important to acknowledge in our practice. And then, fund women-led and women-focused community organizations that do this work, because they are often best placed to work with women in their own communities. And as a data ask, a call to action as it's related to funding, I think we also need to demand that there is more accountability and transparency in funding mechanisms. We need more data around how the money is getting spent, who it's going to, how it's allocated after pledges or commitments are made. But those are my three key points.
Thanks, Sarah. And now, Sean.
Yeah, my pleasure. I just wanted to say I love Sarah's comment on how on the mental health side it's life-saving, and that's absolutely what it is. So true. Our call to actions are really three, and they're all the same. It's really about just increasing investment in mental health, just in the light of time. We know that good mental health leads to better physical health. We know it leads to better economic outcomes. We know it just improves overall life quality. So with that, we just need to invest in this important area.
Great, thank you all for sharing those. I think some really powerful calls to action there, and I'm sure those are going to inspire some questions from our audience. I know that we've already got quite a few questions in those, so it would be great to jump straight to some of those. Okay, so let me see, lots of questions. Our first one, Wendy, I think maybe you could be best placed to answer this. It's, how do you actually collect data on mental health, particularly on women in developing countries where there's just so little awareness around mental health in the first place?
Yeah, thanks for that question. So I think it comes back to, something, of course, that we brought up in the conversation, and it's awareness. So that was one of the calls to action. So even with that question, you can see it's still being highlighted. There's still a lack of information. We still don't understand in developing countries what, stress, anxiety, depression, there still isn't that language. So just by constantly increasing the awareness around it and through organizations, whether it's government facilities, whether it's the NGOs, whether it's a church-based organization, working on the ground, and then use those links and use those partnerships to really be your first point of contact in terms of collecting information, and just even starting by very basic questionnaires, as I said, that would maybe target what are you feeling at a health perspective. I think Sean had this in his, our physical health sometimes will also just tell us what our emotional health might be suffering from, that we're not able to cue to. So maybe starting from that point as we build on the awareness and just the knowledge that people do or don't have about mental health.
Great, thank you. A question here, I think this one is to start with Sean. How do you approach the protection risks of conducting phone interviews, and what mitigating measures are you taking to ensure your activities are respecting the do not harm principle?
Sure. For us, our patient confidentiality, protecting them is always paramount. It's much different now since we're talking to them on the phone as opposed to meeting in person. But it's also following international protocols in terms of anonymizing data, making sure we're doing the right things. It's also when we're reaching out to patients now on the phone, making sure that she has a private and safe space that she can be talking to us. Unfortunately, in some households, the woman on the phone may be accosted by her husband, who are you speaking to, kind of approach. So it's really just making sure that we're in a safe space. And if we can't be in a safe space right then and there with that individual, trying to set up a different time. If ultimately we can't conduct the phone interview, we actually have about 500 volunteers in the slums of Kampala and throughout Uganda who could actually meet with that individual at a social distance and actually conduct the interview as well. So it's really just being mindful of the context and keeping our individuals safe, anonymizing and protecting the data.
Great, thank you. Sarah, I see you nodding along, so I don't know if you'll have something to add to that one, but we have another kind of similar question. One member of the audience asks, in cases where consent for data collection is difficult to confirm or where power dynamics may influence consent, do you still collect the data? What are your organization's kind of hard lines when it comes to navigating those ethical dilemmas? Sorry, Sarah, you're on mute there.
My power and control over my mute is lacking today. But I was just going to add one other example or option to that, to Sean's, that we've been looking at or when working with has been, for clients that we were able to still see face-to-face before our mobility restrictions, our stay-at-home orders went into effect. We did try to confirm if they wanted to be contacted or not. In some cases, we actually had to not take any new active cases for about 2 weeks before we could work out some safety procedures. And then another context, we've established a callback system. So they beep us. So if we get like 2 beeps in a row, 2 pings, we know to call them. So they get to initiate contact. It's not us initiating contact. Again, to be able to, again, give them more control over this space and time that, they are communicating with us. So things like that. In terms of, just to answer the second part of the question, if we are our red line, if we can't confirm consent, if there's any doubt that consent is really happening, we don't do it, right? We don't conduct the survey, or we don't do the questionnaire, or we don't have the call, whatever it may be. In terms of power and control, what those differentials between a service provider and a patient or a client. One of the ways we've tried to mitigate or at least get some insight into what's happening has been to establish client feedback mechanisms that are separate from the service provider client relationship, that are anonymized, to really look at the both feasibility and acceptability of, like, for example, GBV screenings within a health center. Are these truly perceived as consensual? Are these being, administrative in a way that is non-judgmental and respectful? So I think that, really establishing good client feedback mechanisms that really do provide folks with an opportunity to provide information as to how how securing consent is happening is important too.
Great, thank you. So another member of the audience has asked, has the data, which we've kind of established is quite limited anyway, but has the data on shown mental health to decline rapidly at the beginning of the pandemic, or has it been a slower declining curve? What does the data show in relation to anxiety and stress? I think, Sean, if you can maybe answer that first.
Sure, this is a case where the lack of data hurts us. We see now that there's higher levels of stress and anxiety. That's not something for Strong Minds that we focused on before, so we don't have a good baseline when we go to the ministries and others. What have you seen in terms of baseline stress maybe 6 months ago? It's incredibly hard to find. So for us, we're just seeing that it is at incredibly high levels, which for us is a matter of action.
Wendy, do you have anything to add there about the kind of the pace of the decline that you've seen?
Certainly, I think I'm with Sean. There's, of course, there hasn't been any baseline data for us to compare, maybe only just, verbal conversations that you've had and very informal questionnaires, not really, collecting data at that level. And in fact, in my experience, like from the conversations that I have had and the work that I've done, there was more of an immediate drop, right at the beginning, because I think everything was canvassed in all of this fear and, very, like this crisis of, everybody's health considerations. There was just the economic factors all happening immediately. And because, as we've seen, for example, in developing countries, that we're slowly having, a relaxation in what we have as our lockdown rules and our curfews, maybe it's not as drastic and people have settled in more to the fact that, yes, there is this low level, burning stress and anxiety. But the more that we're able to take control of what is the biggest, I think, stressor for me, our economic factors, then you kind of see, it may not be as sharp as a decline as it was at the beginning, but it's certainly still prevalent in all areas.
Great, thank you. Sarah, a question for you here. Given that IRC works in a lot of different countries, and there can be different cultural conceptions around mental health and well-being, how do you kind of go about choosing an appropriate assessment tool from one context to another?
That is a hard and good question. So I think a part of our process, which we have gotten a lot more consistent at, I'm not saying we do it perfectly, but we have gotten a lot more consistent at, is, I think one of the things where we really try to do is to, again, which kind of goes back to my ask, is to identify women's networks and women's organizations to, first and foremost, get qualitative, like we're big advocates of qualitative data, not just quant. And I feel like sometimes when we're talking about data, that's what we're inferring is quantitative data. But to really get qualitative data on, terminology, perceptions around priority needs as it relates to, every, different things, but definitely mental health needs, so that we can get a sense as to like how the community, and more importantly, how women prioritize their needs, how they, articulate again, like how they perceive those needs to best being met. So we really want to kind of ground, or at least get more insight into, again, the community and women's perceptions of the problem first and foremost, before we go about trying to choose an assessment, a specific like diagnostic tool. We have found, and I think my colleagues would have a lot to add to this, but we have found that validating, like a lot of the tools that are out there, they're just not necessarily valid and reliable across the board. And so investing time into really validating certain tools for those contexts is something that we have prioritized. But I guess what I would say, my caveat to that is that it's taken us a couple of, like 18 months to 2 years to really validate. So we really like functionality tools. So tools that look at measuring women and largely adult women's functionality as a measure of well-being. But what is considered functionality across different contexts looks quite different, right? So you need to contextualize it for the context that you're working in. That for us as an organization to do it in 5 different contexts to roll out a functionality tool has taken us, 18 months to 2 years of investment, which again is not particularly helpful in crisis or quick response settings. You just don't have that kind of time. And so our point of departure, which my colleagues might disagree with, and that's fine, but our point of departure is to assume, like, we have enough global data to know that certain types of mental health issues, as well as gender-based violence issues, pre-exist, like they already exist in those contexts. So we don't want to waste all this energy and money trying to prove the problem. Like, we know there's a problem. And that again is always a point of advocacy for us with donors and the international community as a whole, which isn't to say we shouldn't invest in documenting the problem and investing in data. But I do think there is a fine line there between, do you really need to spend all this time and effort to prove the problem just to get a response going in a crisis like that? We really should be beyond that point. But again, happy for other points of view. But that's that's kind of at least for violence against women and girls and their well-being. That's where we're at.
Great. Since that was such a big kind of challenging question, I will give Wendy or Sean if you wanted to jump in at this point with any additional thoughts.
I couldn't agree more with Sarah. I loved hearing her say about, in essence, just don't spend all this time trying to come up with a tool when you know the problem is there. Yeah, I mean, using validated tools, again, when we went into Zambia last year, there were no validated tools for depression. So the option is do nothing or, collaborate with the ministry, agree to use an unvalidated tool, figure out how that's going to get validated over time, but at the same time, begin treating people. Just in terms of, really work with urgency. But yeah, using the finding validated tools. Now we're just in 2 countries, unlike IRC, who's in so many more. Yeah, it's incredibly complex. But yeah, just, for us, I can't encourage enough mental health implementers just to move with urgency.
Well, Wendy, would you like to add anything there?
Not at this moment. I think Sarah and Sean have pretty much covered that. Yeah, that was quite an intense question. And I think I also agree with the person who asked, and I think Sarah did a very amazing job at answering that. Yes, there's so many, cross-cultural contexts that have to be taken into consideration. But I think that's true of any place. Forget even, in developing countries, even if we were to go into one developed country, if we were going to go, for example, into America, there's still such different cultures within America, right? Granted, it's the size of a continent, but for example, in a country like Kenya, where we have 46 different tribes and everybody has their cultural norms, yeah, what do? You just have to kind of start doing the work and then, cross the bridge when you come to it. So yeah, I mean, if we were to take culture into every context of how we do the work, then there's some generalizations that would just make us stop. And I think, yeah, doing the best you can and then moving with intent and making sure that, of course, people's confidentiality has been taken care of and the intent is good, I think is the best way to start and go forward.
And Sean, we do have another question here around data collection tools. So this person asks, what data collection tools on mental health have been particularly useful during COVID-19, and how could they serve to highlight the need for strengthening interventions on gender-based violence with mental health services? So maybe the first part of that question there for you, and then maybe Sarah can jump in on the second part of that.
The question is, what are the tools we're using to collect data, correct? Yeah, it's an evolution. We're using some very simple app-based approaches that we can collect data through our group facilitators, really making sure that they can do that on their phone, so it's easier for them to collect the data. Making sure the data is secure. We upload all the data to the cloud and we're in a real-time data access entry mode now, so we can see the data right away and understand what's happening. It's an ongoing evolution for us, changing the apps, getting more complex in those so that we can collect more information, with skip logic and things like that. Again, for Strong Minds, data is at our core. We've got to have the data, and every year we learn, there's new apps, new ways, and more data that we want to be collecting. And then it's just, again, making sure that you can analyze the data. If you're collecting the data and it's locked in a server somewhere, that's not helpful.
And Sarah, I'll just repeat the second part of that question in case you've forgotten it. It was, how could these collection tools serve to highlight the need for strengthening interventions between gender-based violence and mental health services?
I love that question. So first of all, I would say those tools exist, which I hope is encouraging. The GBV AOR, we can make gbvaor.net, has a series of remote assessment tools that you can adapt, you can adapt to your context and are ideally use. But what I do want to caveat is that these tools are not around documenting incidence or prevalence, right? And stop thinking that way. It's really what I also want to say. You don't have to prove the problem. That's not the type of data you should be trying to collect to both prove the problem and then try to make better linkages. And also, honestly, the incidence and prevalence data isn't really going to help you make better linkages with mental health providers. The type of data that's going to help you make better linkage with mental health providers or whomever is service mapping data, like who's doing what where. Do those services even exist? Service quality data. If the services exist, are they of quality? Are they not? Are they meeting minimal standards? Again, barriers to access mapping. So even if, again, understanding how people can get to, women and girls can get to services or can't, that's the type of data you want to be collecting, right? Because that is the type of data that actually helps you design something that better either links up or builds off of mental health service provision. But those tools do exist. And that's, I guess, also what I want to encourage people and to look at the GBVAOR resources.
So I think we just have time for one more question. And it's, what are some of the opportunities for collaboration between tech companies and the humanitarian sector on building better products and mechanisms to protect individuals and shift power to clients? Sean, maybe we can start with you on that one. And then I think maybe everyone will want to jump in very briefly if we can. Thanks.
Yeah, there's tons of opportunities to partner more closely with tech companies, and we're trying to do some of that, but we'd love a boost of momentum in that sector. For us, conducting groups face-to-face or even on the phone, we feel so often that we have to kind of figure out and answer all the challenges by ourselves. Working with deep-pocketed tech companies with a lot more brains than us in that field. Yeah, how do we get out there? How do we cover larger populations? How do we distribute that information? How do we do the data analysis? There's a ton of spaces there, and there's so many advances right now in all sorts of, remote distance mental health. How can we be doing that? And how do you do that so often, at least in Africa, in contexts where there's very little access to Wi-Fi, et cetera? We'll always get these organizations coming to say, oh, we can do this on the internet. And it's just like, well, so many of our population just aren't on the internet. So thanks, but no thanks. But how do we get over those barriers and really ultimately democratize mental health, for me, at least in Africa, which is our focus?
Great. Mwende, do you want to add to that?
Yeah, that's a really, really good question. And I think I do have to say, for me, when I think about it, I think that, of course, there's huge opportunity. I think one of the ways that we saw, especially in Kenya, with the whole kind of telephone banking, M-Pesa transaction, that there is that capacity to create a system that's text message based, that can connect at all levels, kind of all you need is a mobile network. And Kenya has shown that we have a pretty good connectivity, which is kind of spreading out across East Africa. I agree we're not at the levels that maybe are some of our developed countries, but I think that really is a very good example to show that there is that potential for people to have an SMS-based service where they then, as the question has asked, how do you give the power back to the clients? Are you able to have a format that is very available to your phone? Where you can either ask for help, where it's an SSID service and that kind of thing. I know there has been studies, of course, that have shown that there is outreach that is happening in terms of mental health in communities in Kenya at the ground, using even traditional healers, are very, very basic kind of, interventions with people who work at that level. And I feel like, technology can allow us to come up with some interventions that will link everybody and give the information that's needed once we create the awareness and everybody understands, more about mental health.
Great. And finally, Sarah, do you have any thoughts on where there might be opportunities for more collaboration with tech companies?
No, and not to add to what they've already said. I think maybe just to plug on the opposite end of the spectrum, to not forget low tech solutions. And UNICEF, actually, Dorcas Erskine at UNICEF wrote a really great brief on low tech solutions for psychosocial support for women and girls that I would encourage folks to look at as well. Just because of, again, kind of what Sean said as well. Like, there's just entire communities and demographics that for whom that is not actually a viable option.
Great, thank you all. Unfortunately, that is us out of time for today, but thank you again to Moinde, Sarah and Sean for joining us and for helping us have such an interesting conversation. And thank you to everyone who tuned in and for all your great questions. I'm sorry we didn't get time to get around to them all, but I'm sure we can arrange some way to kind of follow up on those. And we will be sharing a recording of the event and a copy of the slides with you all by email shortly. Make sure to sign up for the other events in our Gender Data series. We are going to be doing our next event next week on June 9th at 11 a.m. Eastern Time. And we're going to be looking at how women are represented in COVID-19 policymaking. Until then, stay safe and healthy, and all the best from the team here at DevEx.